Hello, and a very warm welcome to COVID-19 Updates from Singapore. My name is Caitlin Wee, and I'm a third-year medical student at NUS Yong Lu Lin School of Medicine. This is a series of webinars presented by NUS Yong Lu Lin School of Medicine, National University Health System, and Global Outbreak Alert and Response Network. The COVID-19 Updates from Singapore weekly webinar series will provide viewpoints and insights from a panel of leading experts in infectious diseases and related specialties and disciplines. It is now my honor to introduce you to our moderator, who is also the program director of this series. Recruited to establish an infectious disease training program in Singapore, he was the first infectious diseases head of department in the Communicable Disease Center here in 1992. He is currently Associate Vice President for Health Innovation and Transformation, National University of Singapore. Ladies and gentlemen, Associate Professor David Allen.
Thank you, Caitlin. Good evening and welcome to the 17th installment of our webinar, COVID-19 Updates from Singapore. Your interest in COVID-19 is appreciated, as is your support of our efforts to share what we know with you. We hope this broadcast finds you safe, happy, and well. We'll return to our customary format this week. As usual, our episodes include a review of regional and international epidemiology by Dale Fisher, an in-depth talk by our visiting guest expert. This week, it's Dr. Chikwe Ihekweazu. There'll be a question and answer period with Dr. Ihekweazu, and then an update of current events by Dale, followed by a preview of next week's guest expert and the reveal of the mystery pandemic song of the week. Please send in your questions along with the country from which you're watching. We do appreciate your comments. It now gives me great pleasure to introduce Dale Fisher, Professor of Medicine, National University of Singapore, Yong Lu Lin School of Medicine, Senior Consultant, Division of Infectious Disease, National University Hospital, and Chair of the Global Outbreak Alert and Response Network, hosted by World Health Organization. Dale, over to you.
Thanks, David. So very similar format from me this week. We'll go through some epi updates and try and find some interesting anecdotes and situations that we can learn from around the world, and got some good talking points, bit of controversy and a bit of entertainment at the end. So here I've done the traditional 1 week apart Johns Hopkins University epi curves. It's, I just wonder, David, are we taking this for granted? Are we 1.8 million cases a week? It's just really is staggering, and 44,000 deaths. It's just really hard to imagine how we got into this situation in 2020, but nonetheless, that's where we are. We can expect to start seeing 2 million cases a week soon. The global epi curve, shows that. I guess these dips, I'm sure, represent weekends and reporting times. But here we go. We're sitting on around 5,000 or 6,000 deaths a day, and we're pushing 300,000 cases a day maximum now. You can see the pink, the Wipro area is having a bit more of an impact, and more of that later, but yellow is the Americas, obviously. CRO, the Southeast Asian area, is the purple, that's Indian subcontinent. So we can look at these curves. Chikwe might want to explain why Africa seems to be flattening out a little bit here. That'd be great news if it's true. EMRO's coming down. CRO's got a bit of a relentless spike up, as has the Americas, and Europe's been doing what it's been doing for a few months now with its two epi curves, east versus west. But this is obviously a worrying sign. In Wipro, we've been very, very flat for a long time, but now you can see we're pushing 5,000 cases a day. Still low on deaths, and there's some reasons for that. So if we look across the Western Pacific region, you can see the major places driving it now: Australia, Japan, and New Guinea is an interesting one. Still small numbers, but there's some worrying signs there. I'll talk about a little bit more. So China, the news there is that they've had one or two more wet market outbreaks, one in Dalian in northeast China. That's a seafood processing place. They're still investigating whether it was imported, which as you know, that was the main belief from the Zinfadi outbreak. But they've done what China does best. They've shut down the area. They've got about 190,000 swabs happening over the next few days. And oh no, they've already done the 190,000 swabs, and they've closed everything. And it looks like the numbers are going to be quite small, but nonetheless, there's still this pressure from imported food. Hong Kong is actually responsible for most of the China cases, and I say that without meaning offence. Probably 80% of the cases in China are Hong Kong now, where that they're struggling to bring that under control. About half the cases are unlinked. They've got mandatory mask wearing, although obviously there was a lot of mask wearing already. Rather than quarantining people at home, they're going to start with hotel quarantine. They've got clusters in restaurants and hospitals, care homes. The hospitals are stretched, and there's a lot of concern happening in Hong Kong. Singapore, I'll come back to. Japan, this is they've had about 30,000 cases altogether now, about 1,000 deaths. You remember I told you about those host nightclub places. Well, that seems to be where it started in Tokyo, but it's really spread out through the sort of to the urban areas and the peripheries of Tokyo now. So they're ramping up their isolation facilities, including using hotels. But about 60% of these people are in their 20s and 30s. So this is the main reason why this remains low still, at least at this stage. They've like many countries, they've been trying to promote local tourism, and that was going to be a big thing this weekend. So there's a big discussion now about whether they should just tell everyone to stay home. But it's certainly something to think about when you're trying to promote local tourism, especially in bigger countries, that you might get some spread. So they've got about 1,000 hospital beds for COVID, and they're trying to increase that to 2,800. So a lot of ramping up happening there. Still don't want to call the state of emergency, which is what they had at one stage. The Olympics were supposed to be from the 24th of July to the 8th of to the 9th of August. So we would be in the middle of that. So I guess that was a good call. Australia, I'm sure everyone's up to date with that one. It's the majority of this is out of Victoria, and the numbers, I think yesterday, were over 700. So they've really got fairly widespread transmission. A lot of deaths coming out of the nursing homes, more than 10 a day. So you can see this line going up quite steeply here. So this is a problem since Victoria unlocked. there's been spread to New South Wales, but they seem to be doing a good job to control it. And that's, as I've said many times before, this is about living with the virus, and having cases is not such a big problem as long as you can protect the vulnerable areas, shut down the transmission chains and identify cases early. So that's the situation in New South Wales. But Queensland opened the borders to New South Wales. Couple of girls drove over the border from Melbourne up to Sydney, and then flew, I think. And they seeded a little cluster in Queensland, so they've shut the borders again, I think. So there you go. I just wanted to show PNG. This is a country of about 8.6 million people. It's obviously an unexciting graph. We're up to over 60 cases now, but this is the only graph I could find. So there's been a lot lately, but actually their testing is quite limited. There's a lot of healthcare worker infections, and they really do think that there's a lot of large-scale community transmission potentially happening. So they've closed nightclubs. They've got mandatory mask wearing in public. So I think it's worth watching PNG over the next month. India did a whole lot of serological testing, and they released the results for that late last week, finding that Mumbai and Delhi were over 20%. I think one was 24%, one was 25%. I'm not sure how the sampling was done. I think it would be natural to have a bias, because people, maybe if they've had an upper respiratory illness in the last month or two, they might want to know if they had COVID. So maybe that is on the upper side. But I guess if it's true, these sort of studies are telling us that we could well get to herd immunity, or natural. Some places will get to natural herd immunity before the vaccine's here. I would fear. Bangladesh, as I said, they started charging for tests recently, and their test numbers have dropped from about 17,000 a day down to 12,000. They've also had some floods there, which have made it a little bit more challenging to manage COVID. Their test positivity rate is 24%, which we know is really high. This is really just for completeness again. You can see Spain's had some problems. We mentioned those a couple of weeks ago, where they had to lock down some areas, and some border restrictions have been reimposed on those, I think, between UK and Spain. Italy's rumbling along very nicely. I quite like that epicurve. Germany's got a few concerns, but a pretty strong public health system. So again, it'll be interesting to see where that one takes us. Romania's a little bit interesting. They've had about 46,000 cases and about 2,000 deaths. The country's about 19 million in size. They've had a whole lot of people that ran away from the hospital. 792 people that were actually in hospital absconded because of poor sanitary conditions. So they've passed a law saying that if you're in quarantine or in hospital with COVID, then you're not allowed to leave. So that was, I thought, a curiosity that everything has to surge, and that includes your waste disposal and your cleaning and all that sort of thing. Their positivity rates 4%. A lot of blame. You can see how these, when you do unlock, you can see how so often these numbers go up, and the blame is always with the community. Really, the community aren't behaving. So it's really these failures of community engagement, which, as Chikwe will tell you later, that's always the biggest problem. And if something goes wrong, it's always because that relationship wasn't developed adequately. And this is what we see all the time in Ebola outbreaks and the like. Again, Switzerland, be interesting to see where that one goes. Ireland's looking pretty good, but the Balkan states and Eastern Europe, we've discussed those in previous weeks and the challenges they've got. United States, they've now counted about 20,000 servicemen that have had COVID. So altogether, they're over 4 million cases and 150,000 deaths. It's just incredible. At least 27 states have had to go backwards in their unlocking. So I guess that's a good thing, that there was some response and not just unlocking because you wanted to. Some of these US military, you can see that's sort of a dormitory type situation where there's a lot of men living together in close quarters. But a lot of them have gone to other countries as they get posted. I heard of a case in Darwin in Australia. I heard of one in Japan. So there is a risk of deployed servicemen seeding disease. Colombia, they've had altogether about 250,000 cases and 8,500 deaths. Their hospitals are overwhelmed. They had a thing where there was a rumor going around that doctors were injecting patients with COVID. So this discouraged a lot of people from going to hospital, and therefore there's quite a high death rate in the home, and they don't swab dead people. So deaths at home actually don't count as COVID deaths. So this is generally regarded as a pretty significant underestimate of deaths. Bolivia is another interesting one. They've got a thing that I was reading about in South America where people are ingesting disinfectant, and I don't know where they got that idea from, but this was here's a place that sells chlorine dioxide. I'm not sure what the dose is, but nonetheless, there's at least 10 people that have been admitted for chlorine dioxide ingestion. It was passed by the Senate that this was a legal product and could be recommended for treatment of COVID. And the WHO spoke out against this, saying that you shouldn't do this. So there's some of the high-level policymakers have a push to expel WHO from the country. So it all sounds a little bit familiar, but nonetheless, that's another little. Just when you think nothing else can go wrong, people are drinking disinfectant. I might leave this with Chikwe, but South Africa is obviously the hardest hit country. Nigeria we're about to hear about. We get a lot of these charts from Africa, Chikwe. So it's obviously just reporting, and whenever I see these, I just feel that a country is struggling in its surveillance if they can't give sort of smoother curves, if you like. Namibia had an interesting problem with a healthcare worker who works in a clinic, an HIV clinic. There were 100 contacts at the end of, he went to work sick. There were 100 contacts and 11 staff that had to go into quarantine after that. These are probably familiar stories to many countries that sick healthcare workers spreading disease, which is a bit ironic and sad. In Singapore, our 3 epi curves, obviously with all the increasing cases overseas, then we're seeing more imported cases. So they're obviously all in quarantine. So that's those numbers. Community cases, 3 yesterday, 1 the day before. So this is really a very good effort on Singapore's behalf, that the community cases now probably 8 weeks since we came out of the circuit breaker, still at such low numbers. And the dorm residents, I don't know what to say, it continues on, very challenging. The situation in Singapore, no one in ICU for the last couple of weeks. There's a bit more business in the community care facilities, with 5,000 people still in isolation in those, and no deaths for now about 3 weeks. Okay, I look forward to hearing the master from Nigeria, and I'll see you later. Thanks, David.
Thanks, Dale. Very cheery as always. Please remember to send in your questions in the country from which you're watching via the Q&A tool. We have only 5 questions at this point. We need more. It's my great pleasure to introduce our guest tonight. He's Dr. Chikwe Ihekweazu. He's Chief Executive Officer, National Coordinator, Nigeria Center for Disease Control. He's a member of the World Health Organization's Strategic and Technical Advisory Group for Infectious Hazards. His title of his talk tonight, COVID-19 in Nigeria, Africa. Chikwe, over to you.
Thank you very much, guys. Thanks for having me on your webinar, and grateful for everyone that's joined this session today. I'll try and keep this as informal as possible and keep a lot of time for questions, but I will take us through initially some thoughts on where we are in Nigeria, how we have responded, some of the challenges that we faced, but really we'll be open to your questions from any aspect of this response, both in terms of the response in Nigeria, the response on the African continent, and our response as part of a collective effort, because this, after all, is a pandemic. We all have small parts of the puzzle to play in our different countries, while always recognizing that the viruses that we're fighting don't really recognize all the borders that we draw for ourselves to divide our world. So even though the curves that Dale has just presented are all defined by countries, we always have to remember the context in which we are responding and the context in which transmission happens. So a few thoughts on the outbreak in Nigeria so far. But before that, just recognizing that your audience is fairly global and not everyone might know Nigeria very well. I just thought to put a few facts on of the country because these are important in terms of how we take in the rest of the information that we have. We run a federal government, so we have 36 states with in addition, a federal capital territory in Abuja. And this is very important because in the response to this outbreak in the federal government, it has its unique peculiarities, advantages, and disadvantages when you're responding to an outbreak across the entire country. We have the largest population in Africa, 200 million people, but also the country with the 5th highest population density on the continent. And that obviously is particularly important for transmission dynamics of infectious diseases. So you have to think of Nigeria as a very highly densely populated country and the impact that could have on transmission. Historically, we've spent a fairly small percentage of our GDP on healthcare and health provision. There are many reasons for this. There's a lot of competition for resources in our context. The fact that we're a developing country and trying to rapidly scale up infrastructure, education, we have our security challenges. So there are lots of needs for resources in Nigeria, which makes sometimes spending on health has been, inadequate in the past many years. I think many people are now realizing that that may be is an imbalance that needs to be addressed moving forward. We have a life expectancy of 54, not a number that we're particularly proud of. Continue working to improving it. And in the joint external evaluation that we all use to understand our preparedness, had a score of 46, a score again that we're not proud of, but we're very open in assessing our capabilities, making sure that we have a realistic score to explain exactly where we are to ourselves and define where areas that require improvement. And we've had our fair share of infectious disease outbreaks recently, from Lassa to Ebola in 2014-15, meningitis, yellow fever, cholera. So the response to infectious diseases, really, we have an architecture that has been able to do so severally. What we haven't had ever is an outbreak of this scale, that really affects every part of the country. So a few words on the institution that I lead. The Nigeria Center for Disease Control is a fairly young organization. A few years ago, the federal government of Nigeria came to the realization that in order to have the flexibility to respond to outbreaks of infectious diseases rapidly and to deploy resources quickly to areas where they're needed the most, we needed a national public health institute that can build up the capabilities that is required. So we have a mandate to prevent, detect, and respond. Mandates similar to many institutions across the world. But drawing attention to number 3, where it says specifically support states in responding and lead the response to large outbreaks. But whatever we do, it's important to recognize that we work in collaboration and in support of 36 plus 1 states in Nigeria who actually have the primary responsibility of responding. So this is important in thinking how we develop a response, prevention, detection, and response architecture across the country. We're also responsible for implementing and liaising on the international health regulations on behalf of the country, and integration and communication, collaboration with the international community. This slide just represents the timelines for a few of the most significant infectious disease outbreaks in Nigeria over the past 4 or 5 years. Everyone remembers the 2014-15 Ebola response in Nigeria. This really was a landmark response for everyone on the continent. Everyone was afraid if Ebola came to Nigeria, what would happen? But, we rose to the occasion, mounted a vigorous response, limited transmission to a large extent, and that really brought to the consciousness of Nigeria and the global community the need for a specialized agency like ours. Just on the verge of polio elimination in Nigeria and on the continent, we're the last country on the continent with transmission of the live polio virus. In 2016, August, a few months before being declared eliminated, polio being declared eliminated, we detected 5 cases in Borno, and a state in Nigeria that had security challenges, and that really was a downer in a lot of the work that we did. But a vigorous response was mounted, and since then, no further cases have been reported, and in the midst of this response to COVID, that has now been declared eliminated, and we're in a post-elimination phase now. I won't go through the details of all the others, but we've had big meningitis outbreaks, big Lassa outbreaks, and also the first monkeypox outbreak in many years. Having said that, one big contributor to the outbreaks that we're now declaring has been the improvement in our surveillance systems. So as we have improved surveillance, improved our laboratory architecture over the past few years, we have found diseases that were not easily detectable over many years. And that has led to some of the quote-unquote outbreaks that we've found. And some of these are really as a result of a positive surveillance artifact by improving our ability to detect. Now, I'll go into the COVID-19 situation in Nigeria, and really these are a few summary slides, given the time that we have, and I'll obviously go into a lot more depth during the question and answer phase. We have just over 40,000 confirmed cases since February, when we detected our first case. Cases have been reported in every state in Nigeria. The map shows the states with the highest density are the darker green states. Most of our cases are still in Lagos. Lagos represents 33% of all the confirmed cases in Nigeria. We haven't tested as many people as we would have loved to. We didn't really have the laboratory architecture in the beginning that we could switch easily for COVID. So we literally had to build a lot of the infrastructure as the outbreak had already started. And you all would recognize the big supply chain challenges at the beginning of the outbreak and how difficult it has been to do so. But we are improving rapidly now. We've tested just under 300,000 people. We currently have 22,000 active cases discharged just under 20,000, and just over 800 deaths. So our case fatality ratio is about 2%. We know that there's some underreporting, both in terms of the number of cases and deaths. We don't think that this is as large as you might imagine because our surveillance system is not as developed. Because when people are ill, they will come to hospitals and you will feel the impact on the healthcare system. So yes, we've had a lot of cases and they're being managed, but our healthcare system is definitely not overwhelmed. So we don't think that, especially with the number of deaths, that it's too much out of sync from what we're actually reporting. We're now on slide 7, and this is just a slide to demonstrate the complex response architecture in Nigeria. We have a presidential task force set up by Mr. President, led by the Secretary to the Government of the Federation. So at a very high level, I am part of this task force, but there are several other ministerial level, in fact, most members are ministers, from aviation to internal affairs, from external affairs to education. So everyone that has a role to play in this outbreak is involved in this presidential task force. We are obviously in the Ministry of Health responsible for the health sector response, led on by the minister, and the Nigeria Center for Disease Control that manages the EOC really leads on the public health response. So we have an emergency operations center that works across these 8 pillars of surveillance, point of entry, laboratory, case management, risk communications, logistics, research, and infection prevention and control. So that's how our response architecture is designed. A few words on what we have used to respond. So thankfully, a few years ago, recognizing the complexity, size of the country, we set up a digital surveillance system using a system we call SORMAS, Surveillance Outbreak Response Management and Analysis System. This is a web-based system that integrates critically an electronic platform for surveillance, but also an electronic tool for a response. So as well as just collecting data from lower levels to the top, it also enables you to assign tasks for a response. So whether it's contact tracing, whether it's following up people that have received the vaccine or not. So all the components of the response are integrated into the surveillance architecture, which is why we have really relied on this tool. Now, we were struggling to roll this out across all the states in Nigeria, but the emergence of the outbreak has been, in a way, a blessing for surveillance because it has brought in the resources that we've now used to quickly roll out the system across the country. We also use event-based surveillance, looking across the web, phone calls, and everything possible. Using call centers have been a critical part of the response that we've had to escalate and scale up very rapidly, especially in the beginning of the outbreak. There was an intense pressure on calls from people, members of the public, wanting to be tested, needing to be evacuated into the hospitals. And we simply, at that point, didn't have the architecture to do all of this. So we've had to roll this out fairly quickly to enable a response architecture to be built. We had a very small influenza-like illness hospital sentinel surveillance system, really built on 4 sites across a country as big as Nigeria. Never really have had a big influenza challenge in Nigeria. We didn't really have an influenza vaccination program. So the focus on the ILI surveillance wasn't really as high as it needed to be. But this outbreak has really given us the resources, the energy to scale that up. So all these have had to be scaled fairly rapidly in order to strengthen surveillance. And critically, the part of surveillance that's so important for this particular outbreak is contact tracing. And we are organized at 3 levels of governance: federal, state, and local. And we first started supporting from federal, but very quickly realized that this had to be a state-level response. And now we're working to take that aspect of the response 1 step lower to the local government areas. The second big area I wanted to talk about was diagnostics. So I've said publicly severally, we went into this outbreak with a very low level of our preparedness in terms of the hardware needed for molecular diagnostics. So in many other countries that have rapidly scaled their testing, what they have done is switch the reagents in the platforms that they had already from whatever else they were testing before for COVID. But we didn't have the hardware within which to just switch the reagents. So we had to build the hardware. The hardware is not just the equipment, sometimes even the buildings in which the equipment needed to be housed. We had to quickly train medical laboratory scientists and technologists to actually carry out the testing. And you can imagine what it takes to do all of that when you have an emergency of this size in front of you and people are demanding results, demanding to be tested across the country in real time, questioning us for their results, questioning us for the response. So it's been a really crazy period over the last few months as we've had to build up this quickly. But we've gone quickly from having 5 molecular labs in the country to 60, just under 60 labs right now with the capability of making this diagnosis. We've covered almost every state in the country, bare 6, 7. And by the end of next week, we have teams in almost all the states right now and working very hard to scale that lab testing infrastructure. But the access, equitable access to reagents and equipment for laboratory diagnostics is definitely one of the big topics that will come out of this response and that we have to respond to as a global community, because there's really no point in ensuring equitable access to vaccines if we don't have equitable access to the diagnostics that require us to detect the diseases in order to then respond. So in addition to building up the labs, we've worked on converting platforms for HIV testing, for TB testing, to enable us expand our COVID-19 testing. We've worked a supply chain, centrally managed supply chain for reagents across the country and really ensured a constant stream of reagents in a very difficult context where the global supply chain was extremely challenged in the first place. In terms of the response, again, remember what I said in the beginning, Nigeria is a huge country, large population, large landmass, very difficult to get around. In part of the response was a lockdown initially, and so in trying to respond and prevent transmission, we also had a big impact on our own ability to transfer response materials, commodities across the country. So this has really been an intensive response, getting commodities out, personal protective equipment, first getting them into the country, then distributing them across the country in order for the response to happen at the state level. Deploying people to support the states. At some point, we had 28 teams deployed in real time from NCDC to support the states. So Dale, if you think to what GOAN does for a global community, or what we try to do in Africa, imagine the same happening in Nigeria, but not one after the other, but having 28 teams deployed for whom you have to provide for their human resources, for their accommodation, logistics, in addition to the technical expertise we had to deploy to the states in order for the states to then respond. So incredible logistics effort, human resource management effort in order to respond to this outbreak in Nigeria, warehousing, stockpiling, and everything that comes with it. The next point, I'm now on slide 11, on risk communication. Around the world, this has been a big challenge. How do we communicate to people to do what we think is necessary for them to do? Many countries are now going down the path, and we just heard from Dale about new enforcement of wearing of masks. But we know from public health that using the legal instrument has always been the last resort. Apart from seat belts, there are very few other interventions for which we've had to recourse to the law. We have really often relied on our ability to communicate to people, to enable behavior change, to win over hearts and minds for the response activities that we need to happen. this has really been one of the key focal areas of the work done at the Nigeria Center for Disease Control. We've set up a crisis communication team that is actively responding to messages across the country, with positive or negative, reinforcing positive ones, challenging negative ones, and ensuring that we're always trying to be on top. And every day, almost every day, there's another kind of big rumor that gains a lot of traction, especially when it is retweeted by important figures globally. And we have to then respond aggressively and make sure that we sustain a science-led, a science-driven approach. We have a very active, dedicated website, covid19.ncdc.gov.ng, where everyone across the world can see the guidelines. We've developed our cases, our response, and this resource, this website has been a resource to many other countries across the continent, and they have struggled to develop their own guidelines, so that we are constantly referring to each other's work across Africa, at least, in order to develop our capabilities. We launched a very aggressive social media campaign called Take Responsibility, which focuses on people taking personal responsibility for what they had to do, but also for communities and leaders to take collective responsibility in the response. Recognizing that no country can do this on its own, we've relied on relationships with our international organizations. You know, there's sometimes criticism on the role of WHO. We are very strong fans, and you know, we rely on WHO all the time in the work that we do. So we don't think that this should even be discussed in thinking about the needs that we have. Nationally, we've worked together. The Africa Center for Disease Control has been absolutely critical to build in collaboration and coordination and pooling resources so that we make sure that we're always on top of the work that we do. Of course, we've relied on academic institutions, and critically, the private sector in Nigeria has come together to organize themselves to support the work that we do, so that we make the best use of available resources. So a few reflections on the response so far to conclude. The major challenges that we've had, initially, like I said, the access to diagnostics was a big challenge for us. Lots of states depended almost completely on the federal government providing response material, resources, personal protective equipment, lab reagents, and to get this organized in a supply chain across the country was very difficult. It's improved over the last few months. We continue to struggle with it, and we continue to get better at it. We've had to manage rumors, and this has been a big challenge for us, because every time we work very hard in an already difficult context, then there's a big rumor of a claim for cure or something, some magical solution to this. So we've had to continuously be on top of this game and make sure that we can respond to all of this. I think a global challenge has been our adherence to the non-pharmaceutical interventions. We haven't gone the way of using legal interventions, but really tried to continuously build the trust among people and to counteract the mistrust to government. The lessons we have learned, we need strong global and regional leadership. We need it in Nigeria, we need it in Africa, and we need it in the world. We need multilateralism. We need to find a way to counteract the increasingly nationalistic approaches to the challenges that we have. In public health, there's really no alternative. No single country, rich or poor, can respond to challenges like this on their own. We need to re-inspire a movement for multilateralism in our response to the challenges on health security. We need to address the determinants of healthcare that are outside the health sector and outside the immediate public health areas of influence. as every country pushes towards vaccines, towards therapeutics, towards diagnostics, it is impossible for us to protect ourselves if we don't think about equity in access to these things. So it is very short-sighted for any country to think that by enabling procurement for vaccines in development, you can protect your own family or country. So I'd like to end here by really saying, as we have responded in Nigeria, we really look forward to a multilateral, a global community thinking about health security as a global community, and that's really what we are working on in Nigeria, ensuring that we play our role in Nigeria, but we also contribute to the global response. Thank you very much.
Chikwe, thank you so much. That was a crystallization of a country's response to a unprecedented event. We very much appreciate your insight as obviously an insider and a leader in this response. We've had lots and lots of questions, and so I'm going to try to jump to them and get as many questions as we can in the time we have. We have a question from Aranola Sanyes. Dr. Chikwe, is there anything you could have done or would have done differently about the overall handling of the pandemic in Nigeria? Are you totally satisfied with the handling by NCDC so far?
So we can never be completely satisfied, for sure. And this response, while NCDC has led on the public health side of things, there's been many other aspects that the Presidential Task Force has led on across the country. I really wish, if I think about one of the biggest challenges is really broad, is that we should have thought a lot more in detail in terms of responsibility between federal and state, who does what, how we change tack in an emergency. So a lot of these we have now done, but we've never pushed ourselves hard enough to think through how to share responsibility in a federal government structure. But we have learned, and we are constantly adapting this learning to the outbreak. We're still very much in the middle of it.
Can you teach the United States how the federal and state governments should get along?
We have our own problems to solve, and we're working to solve them.
Okay, next question is from Adrian Cornelia Mathe. What have you learned from community engagement from past outbreaks that have helped you in your country's response to COVID?
So, from every outbreak that we have faced, whether it's Ebola, whether it's Lassa, this engagement with the community from the very beginning never seems to come to the fore till you've made all the same mistakes over and over again. But, this is one reason we have been very open with everyone from the very beginning. And we try to be continuously open with what our challenges are, where our needs are, what we know and what we don't know. And there's often the kind of almost need by leaders to kind of say more than they know in a time like this. And so we think by being open in our communication with people and really saying, listen, we don't know how to do certain things and we need the community to take the leadership in how to get these messages across. And really, that's what we worked on. But this is a hard problem to solve because science is sometimes difficult to communicate. People think that testing, for instance, is as simple as, the pregnancy test or a malaria test, where you get an answer in 5 minutes. And it's very difficult to explain that the process for diagnostics, molecular diagnostics, is a 7-8 hour process. And there are no ways right now, until we do have a rapid test, to shorten that period. So we've learned and continue to learn that open communication with everyone is very important in building trust from our communities.
Thank you. Excellent answer. You're a public health leader with national health concerns. You mentioned that you've repurposed some of your diagnostic equipment from HIV and TB to help roll out COVID diagnosis. What impact is this pandemic having on other pressing health issues, such as mass vaccinations, management of HIV, diagnosis and management of tuberculosis?
So I'll be open again. Across everything you've mentioned, we've seen a reduction in services. We've seen a reduction in access to services. So even when we've struggled hard to keep all those services going, people haven't been coming. And we're not surprised because there's a certain anxiety about the risk of getting infected. And so as we move into what I call the next phase of the response, now that it's becoming clear to everyone that there's no magic bullet that will make this go away, we now have to really think about how to restart all the services. And that's really what we're doing in Nigeria right now. The Honorable Minister of Health and the Ministry of Health is really focused on how to sustain and make sure all the other services that the health sector needs are being provided while we continue to respond to the outbreak, because we can't do one or the other. We have to find a way of doing both in parallel and rebuild confidence and trust in Nigerians to go back to hospitals when they need it.
What's your view on cycles of nationwide lockdowns, whether they're sustainable in Africa, given the lack of comprehensive social support structures to enable people to stay home without earning a salary? What's a reasonable middle ground to protect livelihoods and protect public health at the same time? Excellent question.
Tough question. You know, at the beginning, we all knew the concept of lockdowns was simply not sustainable in our context. So we didn't even go into that period with any assumption that this is something we could carry out for a long period. Because when people talk about lockdowns, there's an important part of what it means that is not part of that word, is do you have the social and logistical infrastructure to provide people what they need for sustenance during a lockdown? And if you don't have that, it's pointless doing a lockdown until you achieve your primary objective. So Mr. President in Nigeria was very clear in the beginning that the purpose of the original lockdown was to enable the country prepare and rapidly scale up its response architecture. And once we've gotten to the stage where we are able to do that, we relaxed the lockdown. Unfortunately, in Nigeria, we have a largely informal economy. We're a developing country. We simply don't have the resources and the social infrastructure to provide that. So we had to find a middle ground. We're trying to find it. The only way we can find it is for the public to really feel that they don't need to be locked down, that they can take responsibility to do the things as much as possible that they need to do themselves to prevent transmission. So, and that's where we've all have to come to across Africa, that we have to work with the countries that we have, not the countries that we wished we had. And the countries that we have at the moment don't have a social infrastructure to provide those resources to sustain livelihoods. But I have watched our leaders make some very difficult decisions, but so far we're working together to find that balance between lives and livelihoods that we need to find in order to maintain the response, but at the same time, maintain livelihoods.
Chikwe, we have another hour worth of questions. We don't have time. We're going to shift over to Dale at this point, but thank you so much. And over to you, Dale.
I was going to ask Chikwe one more question.
Oh, go ahead. Carry on.
It's one that we have to, Chikwe, I don't think you're looking at the questions. You've got no idea how many people are attached to Africa and are writing in questions, but I'll use this one to represent them. It's from Fatima Ojusote. I'm not sure how to say it. Proud to be a Nigerian right now. Thank you, Dr. Chikwe, for that detailed presentation. What is the NCDC doing to ensure public health measures regarding the lab and everything put in place will be maintained beyond the pandemic? We always talk about this, hoping that there'll be a better world after the event. So maybe just a quick answer to that one, Chikwe.
So thank you very much. And I'm also sorry for taking more time than I planned to my presentation. And thanks for all the questions. If I can have access to some of them, I will try to reach out. You know, in responding, I am acutely aware of the responsibility on us right now. That, you know, I don't think I can stand up and face anyone, or any of us can, if by the time the next outbreak will come, which we know will come, We live in the middle of the tropics, large population, warm temperature. There's no better place for viruses and bacteria to wish for than in a context like ours. So we have to use this opportunity. And there's a saying that you never should lose the opportunity that the crisis presents. So we have two strategic goals right now in our response. One is to focus with a razor-sharp focus on what we need to do to respond to the current outbreak, but at the same time, to build up the response architecture for the future. And we're following both in parallel, and every decision we make, we're thinking, are we working towards the problem we're facing right now, and are we contributing to the future? And some of this is what we can do at NCDC, but there's so much more outside our direct mandate. We need to inspire a whole new generation of Nigerians to go into science, to focus on science education, to build the virologists, epidemiologists that we need to work with us into the future. And so this is what we're focused on. And you're absolutely right, Dale. We have a responsibility not just to our generation of Nigerians and Africans, but to the generations for everyone coming behind us to build back better for the future and to be active participants in the future, in our future, in the global conversation. It's not a thing of pride right now that of all the vaccine trials, phase 3 vaccine trials going on globally, that there's just one site in Africa, in South Africa, in Johannesburg, that is participating in vaccine trials. It's not a place of joy for us that when global supply chains for diagnostics, for therapeutics are blocked, we end up in a position of vulnerability. So in everything that we're doing, we're working very hard to start building the blocks for the future. And whether we will succeed or not depend not just on the work that we do, but on the work that many of the Africans that are on this call today will have to do themselves to contribute to the future that we can collectively create.
I'm inspired. Where do I sign up? Over to you, Dale.
Yeah, Chikwe, never a disappointment. Okay, so I apologize to everyone. We're going to go a few minutes over, but I promise you it'll be worth the wait. Three quick ones tonight. Firstly, just quickly on vaccines, then 3D swab printing, and then a word for Nurses Day. So vaccines are 100% the talk of the town. You can't talk to media, you can't open a newspaper without vaccines being the first headline. And as I've said many times, I think it's quite unfair in a way that every piece of information is hot news to make everyone think that there's a vaccine coming. But I'm going to tell you how there can be a vaccine here in a couple of months, even though I've repeatedly said that that's impossible. At the moment, we have 3 or 4 phase 3 trials going on. We have 25 altogether human trials, and we have 139 preclinical trials, okay? So just to remind you, preclinical is all laboratory, it's all animal. Phase 1 might be 100 people where you're really looking at safety. Phase 2 is where you might be looking at dose as well as safety, as well as immunogenicity. But phase 3 is where you really learn if the virus is safe and works. And for that, you might want to do it on thousands. Ideally, some of the bigger trials are looking at 30,000. And that's what takes the time to do all this. And you also have to assess if it protects people. So you have to give them long enough to get the disease so that you can see those that got placebo got the disease and those that didn't get placebo that got the active drug were safe. So this takes time. Now, this is collected by WHO. It's sort of an active collection. It's not that these people are submitting. And you can see this one is the University of Oxford one. I think most of us think it's probably being done the best, and it's probably in front if you want to call it a race. It says 1 dose there, but I'm sure it's 2. And these are 14 days apart. This is now in a phase 2-3 trial with 10,000 healthy adults. There's soon going to be a phase 3 trial with 30,000 people, including children, and they want to watch that for about a year. They'll be looking for clinical and laboratory endpoints. It's being done in Brazil. You obviously have to pick a country with a lot of disease, so it's unlikely to be in the Singapore community. The aim is to detect about side effects that are 1 in 1,000 in terms of frequency. So you're unlikely to identify something that, for instance, is 1 in 10,000. The Sinovac one, this is Chinese. That's also 2 doses at 0 and 14 days. Same sort of time period. I think it's more like 10,000 cases. They're also doing it, their study in Brazil. Sinopharm is this one. I think that one's in Abu Dhabi, and they're also 2 doses. The Moderna one here, this is the one that's getting a lot of talk. This is the one that the US are actually making in large numbers now, in the hope that so you remember I said phase 3, then once it's approved, you're supposed to produce it and then distribute it. So they're reversing that order a little bit now and producing it in the hope that it works, and then they lose it, they gain some time there. But it's a big risk because you might produce a whole lot of drug that doesn't work. That's also 30,000 people, yeah. So, and you can see all these. So these are all the other trials. So these are all phase 2 trials. All these ones are in phase 1, and all the rest still are just being building up towards whether they're worth experimenting in humans. So once the vaccine is here, let's say once we've got safety and efficacy, we've spoken before about vaccine hesitancy, and I don't have a big problem with vaccine hesitancy. I think it's our responsibility to show that it works and that it's safe. But that's all. Hesitancy just shouldn't be excessive. And then you've got to distribute it. But the number of doses matters, because if you have to give it 14 days apart, I'm sure Chikwe, first thing he'd say is, can I have something that's single dose, please? Because finding the second person in the right time frame, finding the same person for the second dose in the right time frame is not always so straightforward. So number of doses matters. There's going to be approaches to different age groups, because the earliest data says that it doesn't work as effectively in the elderly. So maybe they need more, or maybe they need repeated doses, or maybe if it's not going to work in them, you vaccinate the people around them, things like this. So there'll be strategies. Cold chain, if it degrades quickly at room temperature, this will be a problem if you have to have it refrigerated all the way from the factory to the clinic. So this is a well-identified problem. If it's oral, that's obviously better. If it's intramuscular, which most of them are, then you've got to deal with needles and things like that, and sharing of needles and disposal and things like that. And then the whole issue of waning response, is it going to last, or are we going to have to give it to people every 1 year or 5 years? We don't know any of these things yet. Now, here's where it gets interesting. Why? So I received this, and I looked. This was a graphic that looks quite nice, and you can see, oh yeah, here's the Oxford one. It's going to be second half of 2021. The Sinopharm, second half of 2021. Sinovac, a little bit easier. Moderna comes out to here. But what's this red dot? This says potential EUA in September, potential EUA before 2020, potential EUA in autumn. So I'm going, what's an EUA? It says up here, emergency use authorization. And this is a thing, and it's already been used for some of the tests. It was used for remdesivir. So this is when you don't have enough information, but it seems that the risk is outweighed by the benefit of giving it early authorization. So the Commissioner of the Food and Drug Administration, acting under delegated authority from the Secretary of Health and Human Services, may issue an emergency use authorization, authorizing the emergency use of an unapproved drug, an unapproved or uncleared device, or an unlicensed biological product. There's 4 determinations, but I just got the first one, a determination by the Secretary of Homeland Security that there is a domestic emergency or a significant potential for a domestic emergency with a biological agent. So you look at this, does that look like an emergency? I am going to be a little bit controversial here, and I'm thinking the reason why all the scientists are out there saying there won't be a vaccine, it's impossible, it's too short, is because there is a plan to ramp it up in advance, take premature results, and invoke an EUA. I haven't even heard of this as a pathway. It does concern me quite a lot. I think it could actually undermine public trust and faith in vaccines if the pathway is manipulated. So I think, as well as direct harm potentially from a vaccine that we don't know enough about, there could be indirect harm. I think the whole approach could really wind back our outbreak efforts and drive the vaccine hesitancy. And what if this gives a false sense of security and people are taking it, so they wind back all the outbreak response measures, and then suddenly we start getting huge outbreaks again. So I really hope this is not true, but I've only got a little cynical side of me, but this cynical side of me says that this is a fear. If it does happen, then we need to be really intense with post-marketing surveillance. We need to be watching this very closely for side effects and following up and efficacy, and we see. Okay, 3D swab printing. I'll go faster. We were running out of swabs early in the outbreak, so some smart people at NUS decided that they would do some 3D printing and created this Python. They've been done. They can produce 100,000 or more a month. They cost over $1. Plan B is to have an injection molded swab that they can get for 10 cents. So this is future work, but clearly can produce many more. And if Singapore's capacity is 40,000 a day, then you need more than the Pythons. So this has been validated by NUH. They're very sensitive. I understand more sensitive than the usual swabs in many cases. SGH, it's HSA compliant, the Health Services Authority, what's it called? Whatever. Ministry of Health are endorsed, and ALPS, which is a group to provide for the consortium for the medical pipeline, is doing this. There's a publication in process, so we see lots of familiar names there, especially this guy at the end. And when you look here, there you look on the Deputy Prime Minister's Facebook page, and there's the brains behind the operation, including David Allen here. And guess what? You get rewarded when you do good work, David. This is today's cartoon, the COVID Chronicles, and there you are. You finally ticked the box as a cartoon character. Have you got anything to add, David?
It was an incredible collaborative effort, and I'm most grateful for all of those involved. We appreciate the acknowledgement, Dale. Thanks.
Okay, so well done, brilliant work. I might say there's others here. This is Linfa Wang and his work here. So it looks like it's a good pathway, this webinar series, to become a cartoon character. So, David, there comes a time when you have to stand up and be counted, and I was recently persuaded to confront some of my demons. It was by Casey, who's the group chief of CorpCom, so g'day Casey. And this is part of the NUHS team. It's Aaron, Sharon and Shulin. And these three people came up with an idea to celebrate Nurses Day. Because we can't get together, let's do a video singing thing. I was one of those persuaded, but others I think were arrowed or guilted, but actually some have genuine talent, and I don't count myself in that group. There's 37 senior leaders, doctors, nurses, allied health and administrators that have worked with this group. Mike Capella, who have played at the Asian Song Festival, I think Grand Prix, National Day Parade. They first came to fame, I think, with the Sing Off China competition. So I'm going to show you a minute of that now, and then maybe at the end of it, when the credits are rolling, we'll play the whole thing. It's a good bit of fun. So over to you, Joe, to play that minute.
This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now, I'll be strong. I'll play my fight song. And I don't really care if nobody else believes. 'Cause I still got a lot of fight left in me. A lot of fight left in me. 'Cause I still got a lot of fight left in me.
Now I still got a lot of fight left in me.
So that's it for me this week, David. Back to you.
Dale, I am speechless. So I will.
Wait till you've seen the whole thing.
It's left to me to thank Chikwe. We really appreciate him taking time from his busy day to be with us and provide such important insights that we all learn from. So thank you so much. Next week's speaker is Dr. Vutek Chuan. He's assistant professor at the Center for Biomedical Ethics at Yung Lu Lin School of Medicine, National University of Singapore. He's an experienced bioethics policy writer, including works on the topic Healthcare Resource Allocation During COVID-19. The title of his talk will be The Ethics of Immunity Passports in COVID-19, a very interesting, timely talk. There's a chat box tool at the bottom of your screen. We would appreciate your feedback. The chat box tool will be open for another 10 minutes or so. You will also find August registration pages up, so please sign up for August. As you know, we need to re-sign up at the end of the month. There'll be, and until next week, excuse me, stay safe, wash your hands, wear your mask, and send us your suggested pandemic song of the week. And after months of staying home, we're reminded of the iconic song by the Australian rock band The Angels, who asks the important question, am I ever going to see your face again? Good night.
Like a small boat on the ocean, sending big waves into motion. Like how a single word can make a heart open. I might only have one match, but I can make an explosion.
All those things I didn't say, wrecking balls inside my brain. I will scream them loud tonight. Can you hear my voice this time? This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now, I'll be strong. I'll play my fight song. And I don't really care if nobody else believes. 'Cause I still got a lot of fight left in me.
Losing friends and I'm chasing sleep. Everybody's worried about me.
In too deep, then in too deep.
And it's been 2 years, I miss my home, but there's a fire burning in my bones. Still believe, yeah, I still believe.
And all those things I didn't say, wrecking balls inside my brain. I will scream them loud tonight. Can you hear my voice this time?
This is my fight song. Take back my life song. Prove I'm alright song.
My power's turned on. Starting right now, I'll be strong. I'll play my fight song.
And I don't really care if nobody else believes. 'Cause I still got a lot of fight left in me.
can make an explosion.
This is my fight song.
Take back my life song.
Prove I'm alright song. My power's turned on. Starting right now, I'll be strong. I'll play my fight song. And I don't really care if nobody else believes. 'Cause I've still got a lot of fight left in me.
Now I still got a lot of fight left in me.
This is my fight song. Take back my life song. Prove I'm alright song.
My power's turned on. Starting right now, I'll be strong. I'll play my fight song.
And I don't really care if nobody else believes. 'Cause I still got a lot of fight left in me. A lot of fight left in me.
Like a small boat on the ocean, sending big waves into motion. Like how a single word